So welcome everybody, and thank you for attending tonight's third annual discussion on compression. Cannot believe this is our third annual compression discussion that we've had. So as always, I am joined by my PEP co-hosts, seven-time blood clot survivor. Do I have that right, Todd?
Let's
Todd
let's
Robertson,
let's stay at seven.
seven-time.
Yes.
Let's keep it there. And then tonight behind the scenes, we actually have a new team member, not new team member, new team member who is helping us get this off the ground tonight. Teresa Bordeaux, who is a caregiver from North Carolina. You probably all know her. And you know me, Leslie, I'm sitting here in South Florida where it's very toasty. And the guest of honor tonight is Dr. Suman Wasan, who is a member of the National Blood Clot Alliance Medical and Scientific Advisory Board. She is currently a clinical professor of medicine at UNC at Chapel Hill, and a vascular medicine specialist practicing at UNC Health. She is an expert in everything compression, and treats complications after deep vein thrombosis. So she has been our clinical guest the last two times, backed by popular demand. Dr. Wasan, which we're just thrilled to have you this evening. A couple of housekeeping items before we get going. Just everybody knows we are not here to give medical advice specific to you. Please always do speak with your own clinician. This is for educational and information purposes only. There will be a recording of this and it will be available at the beginning of next week. So if you want to rewatch it or share it or send it, it will be available next week. And with that, I'm going to turn it over to Todd so he can lead some poll questions for us.
Yeah. Hello, everybody. As soon as those poll questions pop up, I'm going to read them to you. Here we go. That was quick, Teresa. You are good. Compression survey number one. Have you, and we're going to do this at the end too, but let's just start off with, have you ever been diagnosed with a blood clot? Yes or no? Did your doctor speak to you about compression at the time of diagnosis? Yes or no? Do you currently use compression? Yes or no? And our final question, do you suffer from one of these following conditions? Pain in the legs or swelling in the legs or not applicable? You guys could answer those real quick. We're going to go just briefly run over the results. Compression is always a big topic in the support group and definitely one of our more popular pep talks. So I'm looking forward to it again.
I have to say, post my diagnosis, I found it really confusing what I was supposed to be doing with compression.
That's it with a lot of patients, even today.
Yeah, and I got different responses from different doctors.
Yes. Okay, so here are the results. Let me back up. Have you ever been diagnosed with a blood clot? 91% yes. 9% are in just for some knowledge, I think, and that's awesome. Did your doctor speak to you about compression at diagnosis? Yes, 31%. But here you go, 69% said no, that was not discussed. Do you currently use compression? 61% says yes, 39% say no. And do you suffer from one of the following conditions? 49% have pain in the legs, 55% have swelling in the legs, 23% not applicable. Leslie?
Okay, so we have some work to do here.
Yes.
All right, so Dr. Wasan, you are an expert in all things compression. Yet most of us on this webinar actually really struggle. We were just talking about this with getting the answers about compression from our healthcare providers. So can you, explain to us what is compression exactly? Why is it so important? Why we need this? And I know you have a presentation that you're going to share with us tonight. So if you'd like to bring that up, we can start walking through it.
Think we need to close that poll and start from the beginning. All right, can everybody hear me okay? Leslie, you can hear me okay?
Yep.
Yeah, we're great.
I thank you all for coming tonight. I know evening time is precious, and I'm very pleased to be back here again to talk all about compression. So let's get started with just a bit of background information. So to answer Leslie's question is, why should we use it? What is the benefit? The first thing you want to think about is, why are we using it? And there's two main reasons. One is to prevent the swelling, pain after a blood clot, a DVT. And the other is to treat the symptoms and signs of swelling and pain. The second, treating existing symptoms of swelling, pain, etc., that is well agreed upon that compression is helpful. Most of the studies that have been done actually are about preventing the signs and symptoms of post-thrombotic syndrome. So post-thrombotic or post-clot syndrome has been very well defined, and there's a bunch of scales and scores that have been developed specifically. But these are the main symptoms. People may have pain, swelling, itching, heaviness and cramps, especially at night, tingling in their legs, development of varicose veins of all sizes, redness, skin darkening, and even ulcers. All of these things are a spectrum of things that can occur in people after they have had a blood clot. So
What causes the cramps at night?
So what's thought is that when you go to bed at night, the fluid that is accumulated throughout the day resorbs. That's why some people may tell you they get up and go to the bathroom all night. And they think that in terms of sodium ions and things across the membrane is what precipitates the cramps. If you treat with compression, and we'll talk about that, the cramps can actually get much better. So another reason to look at it.
Can I ask about the itching? Because a lot of patients say that their legs itch and it itches in the clot area. Why is that?
Well, again, this isn't, as we'll get into in a minute, this is an inflammatory condition. And like any inflammatory condition, you can think of it like allergy. People actually have an eczema. Some people get an eczema to this, and that's what causes the itching. Is it's the response to inflammation. The body is trying to deal with what is there, the fluid that should not be there. So I have showed this slide in previous years to look at, these are the, everybody's going to wake up after dinner, sorry about that, with these horrible pictures that describe some of the findings. You can see an ulcer there, some inflammation, that eczema, the darkening. These are all chronic post-thrombotic syndrome, but the majority of people do not have these findings. However, the majority of research is directed at preventing the more severe skin changes that you'll see there. Most people who have a blood clot and develop post-thrombotic syndrome look like this. They may have a subtle amount of swelling. They may have a few varicose veins. They may notice some varicose veins at the ankle, or they may not have any external findings at all. And most of what they feel is heaviness or cramping, and their legs look perfectly normal. So the majority of people who actually have blood clots, especially those that are below the knee, will look more like this. So how does compression work, to Leslie's question? So the vicious storm is you get swelling. This causes inflammation as the body's response, the itching, and then this leads over time to the skin changes. So what happens after a blood clot? If you look at the panel on the left, you see a surface vein and a deep vein. And normally your surface veins drain the blood to your deep veins, and your deep veins, remember, bring the blood back to your heart. In people who have had DVT, two things can happen. The valves that keep the blood moving to your heart get damaged, and also sometimes the veins get narrowed or scarred. All of this leads to the blood pooling at below the knee, and just under pressure, that's forced to the surface. This causes the inflammation. And we know now, not only from just the physiological studies, but there's been some basic science work done, especially from Dr. Andrea Obi at University of Michigan, that there's a large inflammatory response. What we now know is that compression socks, if you look at the right panel, what they do essentially is they reestablish some of the flow of blood from surface to deep. So the amount of inflammation in the skin is lessened. And again, this has now been proven with biopsies of the skin that compression, even at the most basic science level, is helpful, not in reversing, but in controlling some of these more severe symptoms. And so again, in people who have the signs and symptoms, compression, there's no doubt, and every guideline from all the major organizations have recommended that people use compression.
So a question before we move forward, if you can go back to that slide for a second. So with stockings, you're probably going to kill me for this question, but reduced risk of thromboembolism. So does this mean after you've had an initial clot, if you use compression, you're at a lower risk?
Reduced risk of post-thrombotic changes.
Okay.
Yes.
Okay.
Now, people do ask though that same question. Well, if I wear them, does it also reduce my risk of another clot? The evidence points to it, but it's much more anecdotal because it just hasn't been studied as well as this has. So can't
Okay.
hurt, and we'll go through that a little bit more as we go
So
through.
if you're on an anticoagulant, your doctor says take your anticoagulant, you take your anticoagulant, but use your compression stockings, but don't come off of your anticoagulation because
Correct.
okay.
Correct.
Just to be
One
clear.
does not, replace the other.
Okay. Thank you.
So since last time, there's been a bit of updates, but remember, I highlighted this in red. All of the studies have been done to prevent post-thrombotic syndrome, meaning people who were enrolled in these studies had a blood clot and usually within 2 weeks were randomized to receive a sock, which they wore for most of the day, and removed at night, or in some cases, a placebo sock. And most of these studies were out to 2 years. What's new is these studies, the Ideal and Celeste trial, that have looked at typically less strong compression, and we'll look at the grades here in a minute. And what most of the studies show is that there is some improvement in preventing post-thrombotic. That's what the studies are. Now, why do doctors say very commonly they don't work? Well, that is primarily based on the first study called the SOC study. This was done now 20 years ago or so. I was an investigator, and patients were randomized to see wear the sock or not. And what happened is they found that there was no help in preventing post-thrombotic syndrome. This has now been carried over, unfortunately, to most doctors, remembering this was a big splash. It was in major journals. It was the first study to be done. It was all more than 800 patients telling their patients it doesn't work. Well, one, that's not true. It was for prevention. And two, that subsequently now there's further studies that had a better compliance rate that has shown there actually is some data to show that it also can prevent post-thrombotic syndrome. So that's where the problem is that this study became the gold standard, but it was mixed up in terms of what the goal of the study was.
What is so I think we can share this with other clinicians and say, hey, it's not just the SOC study. There are all these other trials that have taken place and you should be aware of them as opposed to just dismissing us that it doesn't work. The reference to the numbers themselves, the 30 to the 40, the 20 to 30, what is the relevancy of that? I know we're going to talk about that, but how low can that number go to actually be beneficial?
So years ago, again, I've been in the field 25 years or so. The gold standard for compression was this 30 to 40 millimeters. And all of you I know on the panel have tried these, and I have too. And the problem with the study, and the reason they think the SOC study failed, is they were just so tight that the compliance overall was only about 60%. And most people who look at this trial think that was the reason it was a negative study. So that's very tight compression, and we rarely use or prescribe that anymore, except for a group of people who may get what's called lymphedema in addition to that. Those patients may be candidates for 30 to 40 compression. But in terms of how low, most physicians for post-thrombotic syndrome would recommend 20 to 30. But we'll talk about the different strengths here. Is that the way these are classified also differs by country. So 15 to 20, I've highlighted the US, is your over-the-counter travel sock that you might see in Hudson News in the airport. That's sort of your basic gradient compression hose. Now, there's ones that are lower than this. There's an 8 to 10. I have a 95-year-old patient, and that's all she can wear. Her skin is so fragile by that age. There's a 10 to 15. But in terms of prescription or gradient compression, 15 to 20 is sort of the lowest. That's your travel sock. 20 to 30 is the one now that's sort of taken over in terms of medical use, meaning people can wear it, and it has now been shown in studies to be helpful. 30 to 40 is now sort of fallen out of favor, mostly because it's very difficult to wear a 30 to 40 compression. They're just very, very tight, although I do still have patients that prefer that. Now, the other thing is most of the name brands that you all have heard about compression, Juzo, Jobs, Sigvaris, and Medi are the big four. They're all European. And so you have to look, Europe itself, the compression is, slightly different. But if you order online, you may get something that was actually made in Europe, and just look at what the compression may be. It's better to look at the number rather than what these classes are, 1, 2, and 3. Does that
That's
help?
interesting. Yes, very much so. I didn't realize that so many of them were even made in outside of the US. Although I think Sigvaris has a plant in Georgia, don't they, where they make their.
Yeah, they're the only US plant. In fact, I toured it. I gave a talk, and it was very interesting looking from thread to where they sold the tag on. They use these Italian machines, but yeah, there is a plant in Peachtree, Georgia. That's not their only plant, but they do have one outside of Atlanta. But there are many, many companies now that are both making and selling compression.
Mm-hmm. Okay. It's interesting. Are they covered by insurance now?
So yeah, that's one of the things we'll talk about with FIT. So they are covered for some people who have federal insurance. They may cover compression for what's called chronic venous insufficiency, which is essentially post-thrombotic syndrome causes chronic venous insufficiency, the same changes. So I've had, for example, some patients who worked for the post office that have federal insurance. The VA will cover them for this indication.
Oh.
What has happened in the last year, and we talked about this last year, is that Medicare is now providing coverage for lymphedema associated with this. So if your doctor says, yes, you have post-thrombotic syndrome with lymphedema, then Medicare now is providing a variety of compression garments, including compression socks, hose, wraps, etc. But coverage is obviously at Medicare rates, and your out-of-pocket cost is something that I always caution my patient between the fitting fee and the upcharge. Sometimes it's just cheaper to get them yourself. So there is some coverage, but it is variable.
Great, thank you. We should actually share that information
Mhm.
with our community because they are expensive.
Yeah, and it used to be that it was very restrictive and you had to go. We're going to talk about that in one of the questions about now. Things have evolved so much when it comes to compression and where to get them.
Is anything new coming down the pike?
Oh, lots new, but what is the difficulty here is although so many people are affected with this, it's not financially necessarily advantageous for compression sock companies to do trials to answer some of the questions that we've just talked about. And so the new things are more not always validated. And that's where it's difficult for someone like me. I'll have my own experience, as will another, physician or a patient or an advocate like you all. But we don't have data to support what's right and what doesn't, other than what I just showed you related to post-thrombotic.
Mm-hmm. Okay. Before we move forward, just a couple more questions for you. So I know we're talking about compression, but there's different types of compressions. Like we see these professional athletes that are wearing these very elaborate compression devices, and you can buy them now and have them in your home. Is that something that works? Is it dangerous? Is it not? Should we be thinking about using them? Or also the benefit of using compression on your arm. I mean, Todd, you were talking about this earlier before we went live, but there's different compression opportunities, I'll call them.
Yeah, I think that is great. I had put some of that in, and I think maybe next year we could do a compression pump mini session. We'll
Oh, that would be cool.
Yeah. So just to put it into some big buckets here, we have compression socks and hose, which is what most people do, which we're going to talk about primarily today. We have compression wrapping and Velcro-based wraps, which may be good for a select group of people who have trouble putting them on, putting socks on, or have different shaped legs or these ulcers, etc. And then we have compression pumps, and compression pumps have two varieties. One is the FDA-approved lymphedema pump, which has specifically been tested with different mechanisms and amounts of compression for patients who have that. And then there's this group that you're alluding to where you can buy a pump for anywhere from $100 to $300 on Amazon. And they're primarily called sports recovery pumps. This is where you see LeBron doing the Normatec commercial.
Yes.
The sports recovery pumps have not been approved by the FDA. And in fact, I had a thing with a patient one who is an avid cycler. They've been called category B, meaning they are not only do they not help, they may be harmful. So I have not recommended those, one, because they haven't been tested. The other thing is the lymphatic drainage system is very delicate. And the amount of pressure over a long period of time, we don't know if that damages lymphatics. And so I've always told my, patients who have this and who are not athletes, they're using it for a different purpose, that again, we don't have data to show that these are helpful and then not harmful. And in fact, the FDA classifies them, have not approved them, and even says they could be harmful. So, these pumps feel good. I've had one on my leg, but whether they work and someone who actually has post-thrombotic syndrome, I would not recommend them. Again, you may have other providers who have had a different experience, but in general, that's what I've seen.
Yeah, and I cringe every time I hear a patient, they've just had a DVT and we're talking 1 or 2 weeks out. And the first thing that they want to do is they want to go out and buy one of these devices and go home and use it. And it's like, that's just not the thing to do, especially with a fresh DVT. When you've just been diagnosed. They sound really dangerous to me in those situations. So I think people just need to be really smart when they're looking at devices like that.
Well, again, I think you bring up a good point. Is our goal of compression, what we're talking about mostly today is people who have had a blood clot are far out from that event, and should they use it for symptoms and signs of post-thrombotic.
Right.
In the acute setting, it's a whole different ball game. And again, what we would typically do and what's recommended is used elevation, wraps, and things to get the swelling down. And then once the swelling's down, consider compression for the reasons that we're talking about today.
Right.
So if somebody has a DVT and time goes by and they are fine, the DVT has dissolved and they're not having any leg issues, do you actually recommend that they use compression? They continue to use compression?
Well, it's based on those signs and symptoms, Leslie, because if they continue to have signs and symptoms, despite the fact that maybe their blood clot has resolved, that would be, the reason to do it. And how people resolve their clot is a big spectrum. You have those that never knew that they had it, both on ultrasound and symptoms. And then you have those that have had multiple clots where their veins are very scarred down, and they're a completely other end of the spectrum. And so the other thing we're trying to do in the medical community is update the language and use the word deep vein thrombosis or clot to refer to right when you get it. And these more chronic changes, because if I were to cut your vein open and look at it, it wouldn't look like there'd be no clot there. It would look like the scar, the same scar that you cut yourself and you see a dark scar. That's what it looks like inside the vein. So the terminology we use in our vascular lab when we know someone's had it for a while is post-thrombotic change. And that is actually now the international nomenclature. So we're trying to get away from words like chronic clot, because then people think it dissolves, and it doesn't really dissolve. Your body resorbs it, but most of the time not in entirety, and often with some valve damage because those valves are very thin and delicate.
Okay. Are there any risks or side effects to wearing compression on a regular basis?
Yeah, so let's jump into the questions because we're starting to get to some of these ones that I think I have in the question. So what I did is for the group that Leslie sent me some of the common questions, so that way we could cover, a lot of base here. So here's one of the things we've talked about in terms of the benefits of compression socks. And again, how long should I wear them? Well, this has actually, again, been studied in terms of preventing post-thrombotic syndrome. So a meta-analysis, meaning they looked at all of the studies and they put them all together to see, is this beneficial or not? And it turns out, indeed, it is beneficial. Is that wearing them, and what has been shown is day, not at night, at least 70 to 80% of the time, at 1 to 2 years, people had a reduced rate of developing these signs and symptoms of post-thrombotic syndrome compared to those who didn't. So again, in terms of preventing these signs and symptoms, compression socks were very helpful based on this compilation of all the studies, many of which I showed you that have been done.
Mm-hmm.
Does that answer your question about how long?
It does. I mean, Todd, you know this better than anybody because you oversee the group, but we get a lot of questions about how long should I be wearing the compression? Can I wear them at nighttime? Can I wear them?
And that question comes up a lot. Should I be wearing them all night while I'm
Yeah.
sleeping?
So it turns out, and that's one of the things I actually learned when I did that tour of the compression factory there, is that the way that these are designed in terms of the compression at the ankle versus up the calf is to be worn when you're walking and provide consistent compression with ambulation. It turns out when you go to bed or elevate your legs, they're actually not quite as effective. And although if people want to wear them, there's not really harm. What may be more effective is taking them off. And if you have residual swelling, you can use a ACE wrap or something like that overnight if you feel like your swelling just doesn't go down just by having your legs up, to reduce it so that you're ready to go in the morning to put them back on when your legs are maximally reduced. Remember, this is a prevention so that you can do, work and do what you need to do during the day. There's no harm in wearing them at night, but it might not be helpful.
I think patients have a lot of fear about sleeping, especially after being just diagnosed. Some of the post-clot PTSD sits in. They're afraid they're going to throw another clot. They're afraid their swelling and pain is going to get worse. And actually, gravity plays a big role, right? I mean, it seems like one of the safest times for you, one of the most healing times, is sleeping when you've got your legs, kind of level with your heart. Just doesn't seem like you would really need the compression all night long.
Yeah, and again, there's nothing wrong with wearing them if you feel comfortable, but it doesn't necessarily help. What I will say is with the medicines that we have now, the new blood thinners that, well, they're not so new, they're out 20 years now. They work very quickly. Nothing is 100%, but within 2 to 3 doses, your rate of having a recurrent blood clot is reduced 99%. They're 99% effective. And in fact, it's now been shown that instead of the old adage of sitting in bed with your leg up after a new clot, it's better once that medicine's on board for a day or two to actually walk. That walking can actually reduce not only the pain and swelling, but may help resolve the clot. So, some people obviously have a lot more pain than others and need to get their leg up and that swelling out before they walk. But in general, within a couple of days, getting up is probably a good thing to do.
And I think that's one of the reasons my vascular guy was so happy to hear that I ride bikes so much. He goes, that you continue to do that. And I forgot to ask him about compression, and I actually tried wearing a full leg compression sleeve while I was biking, and all it ended up doing was fraying, and it wasn't the proper type. But then I never wore that again, and I noticed that I didn't have a whole lot of swelling. And it was like the more I moved, the more I biked, the better I felt. So I'm a big believer in movement. I think getting up, walking, enjoying your favorite activities is really important.
Yeah, for sure. Is there a difference in terms of compression level that people should have if they're, to Todd's point of riding his bike and exercising or traveling or standing or even sitting for a long period of time? We try to discourage the sitting, but Or does it not matter?
Well, in general, if gravity has a bigger effect, then you're going to, feel symptoms more. But if you're using what we call your calf pump, your natural calf pump is using walking is the best exercise, jogging, and we'll talk about swimming. Swimming is another water aerobics, and water water acts sort of as a compression pump, and a lot of people will get it out of the water and see that they're swelling. So if you're moving as Todd's experiences and using their natural pump, then it's maybe not as needed to where the compression. Whereas if you're standing, I recently listened to this podcast. Some of you may remember that Cory Booker did that 24-hour speed.
Oh, yeah.
Yeah.
And so he did this. I was listening to something, and he said that by hour 3, his feet were numb because he was pooling blood. And so he says, I beat up the carpet underneath where I was standing because he had to keep moving his legs in one place because that's what was happening to him. And as far as I know, he hasn't had a blood clot. So just to, if you're going to stand 24 hours and give a speech, then you probably need some pretty good compression.
Yeah.
Yeah. No, that's wow, that's very true. How often should they be replaced?
Yeah, and that is up to, in terms of the quality, how often you wear them. But in general, let's say you have 7 pairs, one for each day of the week. And in general, that should last you about a year, is sort of the rule of thumb. So a good quality one, you would, once you start, you should be able to get them on. But once they're really easy to get on, then that's probably the time that you need to replace them.
So it's perfectly okay as long as you know what strength that you need to use, as long as you have been guided medically, you know what you're looking for. Over the counter compression is fine, right? I mean, it's really kind of a hunt to find what works best for you as far as style and fit, but as long as you have the right compression strength, I imagine that over the counter and ordering them off Amazon, trial by fire, that's okay.
Yeah, and so that gets us in, nice segue there, Todd, to our second question is what strength and length of compression is best? Do I need to be fit at a medical supply or a doctor's office, or can I just get them at the store, the Walmart, CVS, bargain basement, or on Amazon?
Amazon.
Yeah, Amazon or other places. And the answer to that question is different than today as it was 10 years ago. And so now every strength that I showed you, including the highest strengths, are available to purchase without a prescription. It's really how much you want to pay. And even the name brand ones will give you a measuring guide. Usually you typically measure at the ankle circumference and a calf circumference. And then you can look on their little chart, just like you would measure for, if you were buying clothes or something, and get the appropriate length and size. And so it used to be that there were these name brands and you had to be fit and you need a prescription. That's all gone out the window. I've seen people who have $10 ones off Amazon that are better than the $50 ones that they got fit for. So it's very much a trial and error. The other thing I note there is that how long is really up to you. Knee length tends to be just as effective as thigh length, but if you are like Todd and have clots that are higher up with more thigh swelling, you may want a compression hose or even full hose. So that's very much what works for you. But in the end, what you should get is what you'll wear, because if you won't wear it, it's not good for anyone. There was also a question that came in about tall versus short. Obviously, somebody who's 5 feet is going to be different than somebody who is 6'2". Now, most of the companies have either a petite or short, not just the main vendors that I talked about, the Jobs and the Sigvaris, but even there's a local company here in North Carolina called Ames Walker that has a short and also a wide for larger calves. So those are now available. Some companies call them short, some people call them petite, but those are widely available on the internet as well now.
Okay, so it's 90 something degrees where I am. It's probably 90 something degrees where you are, and it's probably 90 something degrees where Todd is. Talk to us about different seasons and availability of compression. Somebody just wrote in, they like the toeless in the summer. I'm with you for that one. What are our options?
Again, I think you have to be realistic. What I tell my young families, we have a beach here, you're near the beach, is that you can't necessarily wear compression when you're walking in the sand on the beach. I encourage you to wear some sort of shoe, though, so that you don't get, a thorn or introduce infection. But go enjoy the outdoors, enjoy the beach, do this and that, and just know when you come in, you're going to have to elevate and get that swelling down. In terms of fabric, there are sheer and open toe compression that are a little bit lighter and easier to wear. I have a number of teachers, etc., that will wear a capri with a open toe sheer. They wear a little slide sandal that hides the seam, and nobody knows the difference. And so there's now all fabrics, there's all colors, there's all options in terms of closed toe, open toe, and as Todd said, even a calf sleeve. Just know that if you end at the ankle, sometimes you'll push the swelling into your foot, so you might want to wear a tennis shoe or something with that. But again, I would say in the really hot time, do the best you can, and if that means you don't wear them for a short time, but then when you get back into air conditioning, do the things to get the swelling down, then that's okay.
Okay, and I just want to touch base again in terms of how do we know it's too tight?
Well, in general, if you are uncomfortable, especially at the end of the day, which most people will be, remember, we're controlling a symptom that you already have. A lot of people will get that cutting sensation, especially at the knee area. You want to pull them maybe 2 or 3 centimeters below the knee. But by the end of the day, that doesn't necessarily mean they're too tight. It just means at the end of the day, you're going to have a collection because of gravity, depending on your job, if you're in healthcare on your feet. Other things to look at are going to be if you start to get, obviously, some irritation. Some people will get what's called a purpuric, a bruising of their skin if they're too tight. And obviously, if they're just too painful that you can't wear them for whatever reason, then, that's something where there's other options where you have adjustment. For example, a Velcro-based option where you can loosen the top Velcro is often a good option for people who have trouble with that.
Okay. I know we talked about replacing, how often we should be replacing, which I'm not very good about. I admit it. And I will tell you all also that I really struggle with putting them on because they're hard to put on. So sometimes I do drop down a little bit in terms of what I'll use because I find them uncomfortable, but I feel like I still get a benefit from the sock itself. So I'm not married to the numbers.
You've got these questions down here. So this gets us right in, what you're talking about is, are there risks and who shouldn't wear them? In general, they're very safe. You should wear what you feel comfortable in. Because if you can't, if they're miserable, you're not going to wear them. There's just a couple of different areas where you have to be careful in people who may have peripheral arterial disease, meaning artery blockages, those with neuropathy or nerve damage, or that scenario right at the start, if you have extreme swelling right when you have your blood clot, you may want to not do as high compression or wait till some of that resolves. There are some companies, again, Sigvaris is one, that make a diabetic compression sock. It still has compression, but there is none in the foot. So in someone with diabetic neuropathy of the foot, it's a terry cloth foot, and the compression starts at the ankle. So it's become quite sophisticated now for even people with neuropathy.
Mm-hmm. Todd, I have another question. I don't know if you want to jump in here or not, but
Go ahead.
so another question for people, if their doctor says you don't need them, it doesn't work, etc., but you have swelling, you have some pain, you want to use compression socks, where do they go to actually get fitted or have the right answers if their clinician is telling them something other than what we need to hear? So we have a lot of people that say, my doctor said don't do it, but my legs hurt, my legs are swollen. Now they need someone to help them determine what is the right number for them.
Yeah, it's really tough. I think when you approach your provider and there's such a spectrum of knowledge and misinformation out there, and now of course we have the internet, and now even more we have AI and chat GPT. In fact, in preparation for this, I thought, well, there's a medical one that helps us search the medical literature. And I tried that to see what it would come up with. And it was interesting what it is. So we all have now the same access to medical information, right?
Yep.
And so that's what makes it very challenging. I have a lot of patients who will come and show me something. I can't know everything about compression. And I think, that if you see and you've listened to, your experience and what you're hearing on these kinds of podcasts and what is vetted in the medical literature, that this helps, you can approach your provider. And then I think the question to ask is exactly that. Well, what is the local resource? I understand that this isn't your area of expertise, but who can I talk to that may be able to help me? That may be a therapist, that may be a medical supply store, that may be, a different department. For example, in the VA system, they do fit for compression in their physical therapy department. I think asking that question about, well, I get, this isn't your area. Not every primary care will know about this. Do you have local resources? And those are different in every area, right?
So isn't it best to, I see a lot of patients, they go to their primary, but they only use them as a navigator to get as far as the hematologist. They don't end up going to vascular. Is there a benefit to seeing a vascular specialist? It's like I wanted to know certain questions that my hemo couldn't answer, and my primary certainly couldn't answer. He knew it wasn't in his wheelhouse, and I went and got a vascular specialist, and it just opened up all kinds of doors for me because I felt like I was getting better, more accurate information. Do you recommend that people see a vascular specialist after a DVT?
Yeah, it's really interesting because I've, straddled both as a medicine physician with an appointment in hematology who's vascular medicine trained, but also is now working with vascular surgeons. I've seen all of it. So all of these groups have actually now come together into this, what we used to know as phlebology. But the other association that I'm associated with is the American Venous and Lymphatic Society, or AVLS, and they have a lot of patient resources. And all of these specialists that you've named that have specific knowledge in this will call themselves, phlebologists or vascular specialists. So, you'll have vascular surgeons that don't know anything about compression, and you'll have hematologists. None of their training, they don't learn about this. They learn a lot about blood clot treatment, but it's just not in their training.
Right.
If you go to the group of the American Venous and Lymphatic Society, and I'm not trying to, give a plug or anything, you just ask the question, you're going to find a list of doctors on their site who know about this from all different specialties.
Okay. Let me just quickly, because we get this a lot in the group, when we're talking about traveling by plane, especially.
There we go.
There we go. Let's just get into it, because a lot of people are wondering, if I've never had a blood, if I've had a blood clot, but I don't have any PTS symptoms, I don't have any swelling, I don't have any pain, and my flight's only 4 hours, is there any benefit to still wearing compression? I'd just love to hear your thoughts on all that.
All right, so let's put it again into two buckets. For those that have had a blood clot previously, especially if they're finished with their blood thinner and they're not on blood thinner, the guidelines recommend that they do wear compression for any flights or long haul travel over 4 to 6 hours, including doing things such as getting up frequently, having an ILC if possible. That is in the guidelines as recommended. So if you
there's a lot of good seated exercises that are really easy to do.
Exactly. And you can't get up. Wearing compression is actually recommended and have been shown to help. If you have, the second bucket is you've never had a blood clot, but you have risk factors, as I've listed there, meaning pregnancy, cancer, recent surgery on hormonal blood, products such as birth control, etc. that's also recommended to wear some compression to reduce risk of a first blood clot.
Mhm.
And those general person who don't fit into any of those categories, there's not a study that shows that it necessarily will help. It certainly doesn't hurt, but the bigger groups are those who have had one or those who have risk factors. It's actually been studied. There was a study called the long flight study that showed that it does reduce your risk.
Okay.
And then you're going to ask me what strength. Again, most of the studies have been done, the very few with 20 to 30, but your travel sock, the 15 to 20 that you see at the airport, seems to be adequate.
Another question related to travel. You have your compression socks. Do you put them on before you get on the plane, or do you put them on when you're on the plane? Does it make any difference?
Typically, you'd put them on at home before you head to the airport, just because you want to put them on when your legs are at their smallest. It's much more difficult after you have a little bit of swelling to put them on.
Mm-hmm.
And it's all pretty much the same advice for driving, right? I mean, there's a difference between being behind the wheel and being a passenger. Being a passenger, I always see it as an opportunity to do some of those leg exercises. But is that time duration, that 4 to 6 hours, that fits in with driving a car doing
Yeah, if you can't get up or you're confined, meaning you're not getting up, stopping at the gas station at hour 1, but you're confined, that's the general time recommendation, anything over 4 to 6 hours.
I've always found that if you stay properly hydrated, which a lot of us do not stay properly hydrated, if you stay properly hydrated, you're going to have to get up anyway. So that's actually one of the
And
best.
have an aisle seat so you can get up, right?
Yeah, right.
So I think we need to, I'm going to ask the clinical community if they can actually figure out time, because you said 4 to 6 hours. I've been told 2. I feel like it's everything in between. But maybe their 2 is without compression and your 4 to 6 is with compression.
Again, I want to be given that we know that there's not a ton of studies, the studies that have been more than 4 hours where this has been looked at. So
Okay.
it doesn't mean that you don't need them if it's less. I'm just telling you what we do know.
Okay.
Yeah, and that's the guidance I think we give in the support group is 4 hours or more. Let me back up to one thing I forgot to ask you about, because just last week I bought my first pair of ankle size compression, just ankle compression socks. I wanted to see what they would do. And to me, they did absolutely nothing. They were actually super comfortable, but they were a little expensive, and then they didn't help me with the swelling. Do you ever suggest those to anybody? Is there any group that could use ankle only? Is that
Not
beneficial?
ankle only. If you think about the schematic I showed you of what the compression's doing, there are people who have most of their symptoms at the ankle because of gravity, and they may need additional compression because of that. But in terms of the schematic I showed you and reversing that flow of blood to make it more surface to deep, the ankle's probably not going to be that effective.
Yeah, but additional compression, that makes sense. That makes sense
Yeah,
for sure.
that doesn't make
I
sense.
know that one of the full length, and I've got a whole drawer full of compression because I never know what I'm going to wear that day. Not in style, but I don't know what I never need the same thing all the time. I'll have my calf sleeve, but if I found out that when I was using the full compression on my leg, and I would use the full foot, that my toes would always hurt by, I don't know, 6, 8 hours in. So I stopped wearing those, and then I started wearing the ones that cut off above the toes. But then I would get this deep line gashed into my skin that would burn like fire. And I said, screw this. I even tried wearing an ankle sock underneath that, and that didn't help. But that's why I have such a variety, because even though they're all the same strength, I find that sometimes my legs can take it and sometimes my legs can't. But I am very happy with my calf sleeve, even though my chronic clot is thigh to ankle. My blood doesn't seem to be pooling in the foot. I don't seem to have a lot of swelling in the leg. I think I'm really lucky because I'm told that I've got PTS, but I got to tell you, I feel guilty sometimes because I don't have that pain. But wearing the compression is helping to prevent that, from coming on. So I know the importance of that, but I feel bad because I just have to deal with moderate swelling with this big thing and not the pain. And I see a lot of people suffering, and it's hard to watch that.
You are very lucky.
Yeah.
Um, just in the interest of time, let's talk about lifestyle quickly. And then we have a lot of questions, and I really want to get to as many questions as possible. So, a lot of people took the time to send in their questions, and folks in the group have sent them in. So let's see if we can get to some of these tonight also.
Yeah, just to finish up with a few questions again, what are some other things that have been looked at to reduce, again, the signs and symptoms that Todd describes? We've talked about walking and swimming, elevating your legs. We have a lot of Amazon sites here, and I have people that, I say, well, if you can get 30 minutes at lunch and just put your legs up on the chair while you're eating your lunch, obviously normal body weight, salt will increase swelling, just know that will happen if you have some barbecue. There are some herbal medications that have been found to help, but there's not a FDA source and no long-term studies. So these may be helpful in a select group of people who have ulcers. And then we briefly touched on the lymphedema pump. Again, probably best done through someone who, physical therapist who is certified in lymphedema treatment.
Great. All good advice. So I think let's move into some of the questions. I'm going to kick it off, and then Todd, we can just kind of bounce back and forth.
Okay.
Although there is one question that I'm going to get to. I'm taking two because I want to know this because this is me. So Denise writes in, are yoga pants good? They're tight like compression socks. Can we count those as compression, Dr. Wasan, or is that a no?
When people are hesitant, you talk about compression and you see the look on people's face when you even say it, right? That's why some physicians don't even want to bring it up. I often will tell women or men to start with athletic leggings, like you see at the Olympics. That has compression, even, the old legs pantyhose has a degree of compression. Just start low, see what benefit and tolerance you have, and move up. That's probably better than starting a high strength, one of these prescriptions, and then being miserable and then never wanting to try them again. So anything with spandex, athletic leggings, if that's where you want to start and to see if there's some benefit, I think that's reasonable.
Okay, so there's hope for us with the yoga pants. Second question, are ablation procedures in the leg an alternative to compression?
So I do, full disclosure, I do the ablation procedures. And in someone who has had a blood clot with post-thrombotic, that decision tree is different than in someone who may have varicose veins and never have a blood clot. One of the things you have to keep in mind is when you close a surface vein, in some cases that is your venous drainage because the deep vein is scarred down. And it used to be that we thought that we would worsen the symptoms if we did that. That's now changing also. And we're learning that the deep veins of the muscle, which we can't see on ultrasound or even a venogram, play a bigger role. And so there's some new studies that show that in certain cases, closing those veins or ablating those veins, even if you have the scar down veins, may be helpful. But the decision tree is a little bit more complicated in terms of how you approach those patients. I like to start and do the minimum and see the effect because you can always go and do more. That's how I approach those people. And in particular, those who have either severe symptoms or severe skin changes such as ulcers.
Great. That's really quite interesting. Thank you. Todd?
So what about in the group? I mean, we see so many different things happening with patients, so many different kinds of patients. Arm blood clots. I've seen this with local drummers. I've seen it with golfers. I've seen it with baseball pitchers. If you have a blood clot in your arm, you can wear compression, correct? Is there anything that anyone needs to know about? I mean, what do we need to know about arm compression?
Yeah, again, the arm blood clot, again, it's in two big buckets. There's something called effort thrombosis, which is what you described. Guitar players, pitchers, athletes, people who go always in football season when they start, rowers. That's a different anatomical clot. That's typically the treatment is reversal, blood busting therapy as well as a surgery and some compression after, usually temporarily. That's very different than the cancer patient, who's the other big group that has a central line, who is getting chemotherapy, that may have had some of their lymph nodes removed and swell. Again, they do get post-thrombotic syndrome of the arm, and a compression sleeve can be helpful. So the arm is, again, a little bit of a different bird, because most of what we see, and I won't say most, but much of what we see, especially in younger people, is what's called effort thrombosis. The other word is Paget-Schroeder disease.
Okay.
Yeah, we were just talking about that. When does PTS transition to lymphedema? What is the difference? I've been diagnosed with both and have been wearing 30 to 40 stocking for 30 years as recommended by my hematologist. I'd love to be able to move to 20 to 30.
Yeah, so again, you should wear what you can wear and what helps you. And as you see, the studies now are changing a little bit. So this has also been an evolution in the medical community. Lymphedema as a extension of post-thrombotic syndrome wasn't really on the radar. But as we've learned more about lymphatics, we've learned that the two go hand in hand. If you have post-thrombotic swelling, where you know, doctors love to make that little mark, that indentation. The community now has evidence that shows that that means that your lymphatics are either damaged or they're just not keeping up. So they may be fine, but they can't keep up with the swelling, or they also may be scarred or damaged from some of these skin changes that do it. That is called lymphedema. So they're now going hand in hand, this post-thrombotic, chronic venous insufficiency, and then lymphedema. So many in the community will say, if you have swelling, you have lymphedema. And that's where the prescription of the lymphedema pumps and treatment has, you know, taken hold.
Okay.
I've got a
Great
question.
question.
Yeah, I got a question that came in from a patient, and I'm dealing with a chronic clot myself, but is there a certain time limit for a chronic clot? If I've had a chronic clot for 3 months, is it too late to remove that? Is it too late to have a thrombectomy, a surgery on it to remove those?
Yes. So this is a really great question, because just know that anybody, that what it shows is the natural history of resolution is a person with a clot, anything above the knee, anywhere above the knee, only 50% of veins will be normal by 1 year. Those veins can remodel, and it's not unusual to have some scarring. It's not clot, it's that post-thrombotic change. The actual clot, you know, you cut yourself and you see a jello clot, that goes away within about 4 to 6 weeks.
Yeah.
And what's left over is what is this forming scar tissue, no different than if, you know, you cut yourself and you got a scar and you watch that scar heal. So at 3 months, depending on the extent of the original clot, that post-thrombotic change may very well be there and may take some months to resolve or not at all. And that's okay, because we know the body can adapt. I've seen people who have full leg clots that don't resolve, that have minimal symptoms. And I've seen people that have ones that are just below the knee that have resolved mostly, that have more symptoms. There's not always a complete correlation.
Can you tell us what are collateral veins?
So we are born with a network of arteries and veins. So we don't grow new veins. But the analogy I like to use with my patients is, let's say you're going down the highway and you're going 70 miles an hour, and all of a sudden one lane is closed. Well, now you're going to slow down, but what are you going to do? You're going to get on the feeder road. You might go through the neighborhood to get where you're going. Those streets were there. They're just carrying more cars now. And that's what the body does too, is that some of that is pushing it to the surface veins. Some of it is going through those muscular veins, which are maybe the neighborhood or the feeder road. So that's what a collateral is that we see those veins that we wouldn't normally see get bigger because they're carrying more blood.
Yeah, that's a great explanation. That's exactly what my vascular surgeon told me, and he described the whole freeway scene and everything. It really helps to have that picture so you can understand what's happening. So
Yeah.
thank you. Leslie?
That is a great picture. I have a large varicose vein in my thigh. Is knee length compression okay?
So in terms of varicose veins, it's again, some people do feel like if they wear a thigh high over the vein, they get more relief than if they wear a knee high. If you flatten the vein, it's less engorged and you may feel better. So it's more about symptoms than actually whether it's dangerous or not. Again, I would wear what I would wear. Typically, if you have the development of a thigh vein after a blood clot, it does mean that those veins are pretty scarred down, and that vein is developed as your collateral, as your feeder road to get that blood back to the heart. And then back to the question I didn't answer about thrombectomy, you know, just as Leslie knows, we work with a talented investigator, Dr. Vindantham from Washington University, who is looking at whether we should open chronically scarred down veins, especially in the pelvis versus not, to improve these very symptoms. And I don't think it's, I'm not violating any investigator confidentiality to say that he is now finished recruiting. And we hopefully, as we finish the follow-up here in the next several months, hopefully we'll have some early results by next year.
And that will be great to share with everybody. We're really anxiously waiting what the outcome of that is going to be. When going on a long hike, 5 to 10 miles, that is a long hike, for several days, should I wear compression socks? I'm still on blood thinners.
Yeah, I think if you can and it helps, you know, a lot of people feel like their exercise tolerance is better with them, then I certainly would do that.
Okay, great. Continue. Thanks.
This question was actually asked like 2 or 3 times. Is it okay to use a lidocaine patch on a calf for post-DVT pain?
Yeah, so the lidocaine patches, again, the ones that are over the counter, there's some cream, there's a spray and that sort of thing. Typically, it takes about 20 to 30 minutes for them to work, and then they may last an hour or two. So I think if you use them, you know, once in a while for severe pain, they're fine and safe. Lidocaine can get absorbed into the system. So if you're using it continuously around the clock, you just have to be careful about that, because it can cause, you know, we use lidocaine in the IV for heart rhythm. But, you know, for a short amount of pain in a localized setting, it's probably fine.
What about the topical creams that have some NSAIDs in it?
Yeah, same thing. I actually do have mostly people with knee arthritis that use that Voltaren cream. Again, it acts, it works for a few hours, it's gone. I think that's fine. There's seems to be less stomach problems with using the creams.
Yeah. Okay. Leslie?
I had a DVT with my first pregnancy, nothing with my second. Should I still wear compression socks?
So the compression socks, again, I think this is good to highlight here towards the end of this, our time together, is that it's to treat the signs and symptoms. If you have no signs or symptoms from your blood clot, you don't necessarily need the compression. Remember, the studies have shown after a clot, it can prevent. Now you're far away from that. Or if you have signs and symptoms, it can manage those symptoms. But if you're in neither category, you don't necessarily need them.
Okay. Todd, I think maybe one more question. We've run over tonight. Dr. Wasan, I know this is a heavy ask, but would love to maybe see if we can come up with some kind of material to give people about compression so that we don't have to wait 12 months to get you back for the 4th annual event, and then people can come to the website and also get their questions answered, because there is some overlap with folks. So I'm going to hold you to that to see if you can work with us on that. And then Todd, last question, and then hoping that folks will stick around because we have a few poll questions at the end and we really want feedback.
Yeah, and I love the idea of having like 1-minute videos and things like that where people
Yeah.
can to find out a lot. I had a couple people ask this as well. Is it normal for compression socks to cause more pain and swelling? Or is that an indication that something's really wrong with the strength?
You know, everybody's pain tolerance is individual. I would say in general, these compression socks are something that you should use to prevent the symptoms during the day. So if you wake up and put them on, that's the maximum time to use them. But if you have swelling and you put them on, that's where you're going to have some of those problems with pain.
Mhm.
And so again, you know, get the swelling out with leg elevation, some wrapping, and then try again, potentially with a lower strength.
And trying to elevate and keeping ahead of it's really important. I found out that if I did it before I started really swelling up, I didn't swell up as bad all night. So I got really used to elevating like constantly when I'm sitting. Okay, Leslie.
Okay. I think that's the last question we're going to take. We're gonna try to answer some of these online for folks. But why don't you bring up the poll questions and then we'll let everybody go home for the evening.
Okay, so only 2 questions, folks. If you could please answer these real quick. Are you interested in receiving more information about compression from the National Blood Clot Alliance? Yes or no? And do you feel more qualified to discuss compression with your doctor post tonight's event? Yes or no? And let's quickly just read those real quick. Don't forget our next pep talk coming up in August is aging. It's about aging and blood clots. Hello, that
Hello,
fits me
back
to
at
a
you.
T. It fits me to a T. So we hope that you folks will sign up for that too. I'm looking forward to it. So we'll see if we get the results here. They should be popping up. Here we go. Are you interested in receiving more information about compression from the National Blood Clot Alliance? 90% said yes. Do you feel more qualified to discuss compression with your doctor post tonight's event? 95% did say yes. A very small percent, 5% said no. Yes.
Thank you, Todd. The slides, can we keep the slides and have them on the website for people if they want to refer back to them?
Yeah, let me just make sure that I've referenced everything appropriately so I don't get in trouble. And then we can talk about that offline.
Great, sounds good.
Awesome.
Thank you, Dr. Wasan, Todd, everybody that joined tonight, and Teresa for being our mastermind behind the scenes here. We will hopefully see everybody in August.
See you then. Thank
Good
you.
night.
Thank you, everybody.